session. Today we are having a topic on gastrointestinal symptoms. It will be taken by Sister Stella. So we can start with ma'am's presentation. We can have it for around 40 to 45 minutes, followed by 50 minutes of discussion. By 4, we can have our case presentation, followed by its discussion. We can wind up our session by 4:30. Thank you all for joining in. Over to Sister Shiva.
Good afternoon to all. As Rajashni said, today we are going to learn about gastrointestinal symptoms. So you might have seen many gastrointestinal symptoms in your settings. But in palliative care, we have seen two symptoms, especially nausea and vomiting and constipation. This session will be handled by Sister Stella. I hope all of you are familiar with Sister Stella. She was our last week faculty. Sister, welcome back and over to you.
Thank you, Shiva. Okay, I'll share the screen. Arun, can you see the screen?
No, ma'am.
Huh? It is paused, it is said. Okay, 1 second, 1 second. Now?
Yes, ma'am.
So once more, good afternoon to all and welcome to this session. Okay. So I'll be asking some questions and you can answer in the chat box your responses. And meanwhile, whatever queries and all, as Shiba said, we will do it towards the last. Okay. So as Shiba said, in palliative care, every day, we come across nausea, vomiting, constipation, diarrhea, lot of GI symptoms we come across. And especially not only the patients, the family members also do encounter with this. So as a nurse, what is our role in managing such cases? So here again, as I said, I'm not going to detail of the pharmacology because doctors will be ordering medications and we are the persons to do it. But only thing is that order has to be carried out properly, effectively, and also documented properly. Okay. So a nurse's role in the management of first nausea and vomiting requires excellent assessment skills. So I don't tell only about nausea and vomiting. For that matter, for any symptom, an excellent assessment skills is very important, including the knowledge of we should know about the physiology, current pharmacology, and non-pharmacological interventions also. For example, if you know what all the medications are given for vomiting, at least you should know the names of the medications because patient will be on number of medications. So you should not get into confusion that this medication is what and this medication is given for what. Okay, so you should know the pharmacology, especially the names of the medications, and of course, important is non-pharmacological interventions for the nurses. And in advanced cancers, more than 50 to 60% of the patient do suffer from nausea and vomiting. And of course, this is a distressing symptoms because the quality of life decreases. And it is family and the caregivers, both physically and emotionally are affected. So nausea, vomiting can lead to multitude of physical, psychological, and social problems. And especially when we talk about emotional or social, psychosocial problems, see, vomiting in front of others, it is really, what to say, it is a very emotional state that time. Many people feel embarrassed when they vomit in front of others. What these people will be thinking about me? And of course, when you are sitting and having your food and someone vomits, that also gives a lot of problem. So let us see what it is exactly. So nausea and vomiting and constipation I will cover, and if the time is there, I'll give you little this one highlight little about diarrhea. So nausea is an unpleasant feeling of the need to vomit, often accompanied by pallor, cold sweat, salivation, and tachycardia. May or may not be, not for all, but the feeling, back of the throat, we feel something, some different taste, feeling like vomiting, but we are not vomiting. Many of the time, people will say only saliva is coming. They just feel that nauseated feeling. But what is vomiting? Vomiting is entirely different. Vomiting is the expulsion of whatever there is in the this one gastric content. Whatever is there, it comes out of the mouth. And retching is a rhythmic, labored, spasmodic movement of the diaphragm and abdominal muscles. Retching. Some movement happens in the diaphragm and the abdominal muscles, everything that's spasmodic, that is retching. And one more thing is called belching is there, where only the air will come out. Some people will do like this, so only the air comes out. Okay, and of course you all know about regurgitation. Whatever is our, whatever is there is in the stomach, it is regurgitated back. It comes into the mouth. So these are the some of the different things that we'll be using. So before going into, you all must have, most of you must have experienced nausea and vomiting. And of course, the little elderly people do experience belching and sometimes even regurgitation. Regurgitation, especially when we take a multiple foods, a different type of food, sometimes it doesn't get digested and it starts coming out. The same thing we must have seen in patients also. So usually the etiology, when we talk, a lot of causes are there. If we were sitting face to face, I could have asked you to put some in writing, what are the causes? So chemical causes are there, gastrointestinal causes, cranial causes, and other causes also are there. So let us see some of the causes. Some of the causes are like drugs are main of the causes in palliative when we talk about opioids. Leave other things. Opioids is one of the things. Then toxins like food poisoning. Then any metabolic organ failure like hypercalcemia, ketoacidosis, hyponatremia, uremia, this all will cause vomiting. So usually what we say is we have to treat and reduce the offending drugs. And so if you talk about opioids, what we say is if opioids is given, laxity has to be prescribed. Treat the underlying cause. That's the best thing. Treat the underlying cause. And for the opioids, the drug of choice is always haloperidol. Of course, in some cases or some places, we use metoclopramide. That is what we call as this one, regular. So opiate can cause nausea and vomiting through different mechanism. I'm not going to the mechanism. The thing is, whenever in opioids, when we have nausea and vomiting, what to be done? I will come into the next slide. Now, gastrointestinal causes. And many times, like drugs, not only drugs which we have, especially if you take NSAIDs, we are not taking with the food. What happens? They will have gastric problems. Ascites will cause, gastritis will cause, hepatomegalia will cause vomiting sensation, means nausea and vomiting. Sometimes even constipation. So the assessment is very important. Then irritation, liver mets, ureteric obstructions. So what can be done over here is usually the treatment, as I said, underlying treatment cause has to be treated by reducing gastric secretion. Prokinetic agents can be given. And if there is a constipation, active bowel management has to be done. And if there is intestinal obstruction or some tumor, some corticosteroids can be given. Okay, so these are about the treatments. Now, when they come, it's a cranial causes, cerebral edema, intracranial tumors, intracranial bleeding, when there is trauma. So usually they have, because when we work in trauma unit, we ask, na, had a nausea or vomiting after the accident and all. So these are same. When there is a cranial issue, too, the patient will have vomiting and nausea and vomiting. So treat the underlying causes, and of course, with medication, whatever has to be given, that has to be given. And especially when we talk about palliative care, when there is intracranial tumor, a lot, we try to shrink the tumor by giving high doses of corticosteroids. Other causes are like movement associated. Again, like sometimes due to the movements patients will have, sometimes even when we have that syncope and all, sudden, this one, we feel like nausea and vomiting. Cardiac problems can cause nausea. Anxiety can induce nausea and vomiting. Just thinking only we will have. Anticipatory emesis also happens, especially when patients are on chemotherapy. Already one chemotherapy, the patient had vomiting after 21 days. When the patient comes to know, tomorrow I am going for chemotherapy, the patients will start nauseated. Some even starts vomiting. So the previous experience, that is another thing which causes them for nausea and vomiting. So the main thing we are coming, the assessment. As a nurse, what are the assessment we have to do? Onset is very important. When it started, when did it begin, that we have to ask, and how long does it last? And does it occur often? Or it is all the time you are having? And again, you can ask a question, before this onset, how it was? Like, I started vomiting since past 2 days I am having, that is the onset. But before that, I didn't have much problem. So what are the provoking and palliating things? Provocation. What provocates? Some people you must have heard saying that after eating food, I keep vomiting. And of course, what makes it worse and what makes it better? So both the things we have to ask the patient. And the quality, what does it feel like? We can ask them to describe it. You know, people say something will come round from, they will touch and show your abdomen. They will say it rolls and rolls and it comes out. So what do they feel during that nausea and vomiting? If they can explain it, that will be good. Just ask them. And do you have this nausea with or without vomiting? Some people after nausea, they will vomit. Some people don't vomit. And what is the severity of it? It is very intense. Like I just vomited very badly, bulk. Or it is just little bit I am vomiting. So mild, moderate, severe, we can say. Some patients will explain to you whatever I had, it has come out. Nausea also, there is severe nausea, severe feeling of nausea. And some people with nausea, they even faint after feeling that nausea. That's why so they feel sweating, tachycardia. They start sweating very badly because of that nauseated feeling. That comes very severe. Then goes for the treatment, whether it is treatment related or with the treatment, it is okay for the patient. Suppose patient was already taking some medication, she says with the medication, my nausea and vomiting is controlled. Or is it treatment related, like because of chemotherapy, you are having vomiting, but the patient is in some drugs that causes vomiting, the side effects of the treatment. So that we have to ask the patient and find out what are the medications the patient is taking. And in this, the impact or the understanding, the impact of that symptom on the patient and the family, that is the effects on the patient and the family. How the family is taking overall about that. Now, what is the patient itself feels? Maybe he's disturbing others because of his vomiting, they are not able to eat food properly. Others People are standing and looking at him. Maybe there are some people are taunting why he keeps on vomiting. Whenever we are having food, he starts vomiting. So a lot of things are there that can affect the patient's nausea and vomiting for the family and others, and especially in a hospital means it is worse. So, like when we talk about prokinetics, like when it is in promote gastric emptying, especially metoclopramide, it's very good. In most of the palliative, we use it, and useful in gastric stasis also. And only thing is, if not settling only, then we go for some IV or something like that. Usually, we go for oral things. Haloperidol is a choice of drug for opioid-induced vomiting. And still the patient is vomiting. Now we have started only orally, and still the patient is vomiting 2-3 times more. Then we have to consider, I just wrote syringe driver, but we have to consider the patient to put on some IV injections. So that will be better, IV or subcutaneous, whatever it is, okay? And the other thing is, choose a route of administration that ensures the drug reaches in the site of action. And this often excludes the oral route. Suppose a patient who is vomiting and still you're giving orally, there is no use of it. So we have to change the route. So we have to think about this because it has to reach as fast as possible so that we can reduce the vomiting or control over that. And in some cases, we have to titrate the dose and of course, review the patient very frequently and see that the antiemetics are given regularly. And still the symptom persists, then we have to review it for likely causes. Especially in palliative care, constipation is one of the causes we say. Drugs, as I said, many of the drugs can cause. Wound, that wound smell, bad smell, fungating wound. Ascites. See, I showed you a lot of other causes also, but I'm just telling you. Ascites can be a cause. Even in some patients in terminal, they feel nauseated. So we have to find out what are the actual causes for the vomiting. We can just sit with the patient and sometimes even the smell of the medicine, or maybe at home, the patient is vomiting because of the smell, whatever they are cooking. The smell of the food, that also will cause vomiting, nausea and vomiting. So see, this all will have an impact on the patient and of course, on the family also. So usually we'll go first for a nutritional advice is to eat small frequent meals than taking a big large meal. Ask them to take very little food, very frequent meals they can start taking. And try to take more of food in the daytime, I mean frequency. Then many people they find the breakfast is the best time. Eat foods and drink that are easy on the stomach, in the sense easy digestible, what I mean. Some foods are there, especially if you take the Indian scenario, even in the morning time also they will eat nice spicy food. Especially the gravies, curries, what we say, it will be very spicy. And some food they call a steam cake, we say in our language, we say puttu and all. Okay, like that. Some food is there which causes gastritis and ultimately patient will have nausea and vomiting. So the patient, we have to ask the patient what type of food they are eating and then specify and ask them, when you eat this food, do you have nausea and vomiting? And if the patient says, yeah, this type of food when I take, I feel nauseated or I feel fullness, and then after that I vomit. Then ask the patient to avoid such food. For example, I'll tell even cucumber and apple. Some people do have after taking, it won't digest. It will be there in the stomach itself. and the patient will start feeling fullness. Then slowly after some time, indigestion, then they will have nausea and then vomiting. So each food we have to ask, specifically we have to ask what type of food they are eating. Any food which they are eaten anytime has caused some disturbance, some discomfort. And do not force the patients to eat when they feel nauseated and when they say, I do not want to have food. Some people tolerate better cold food than hot food. So that can be, otherwise it should be in a room temperature. It is not that hot you brought out from the oven and you are keeping in front of them. And of course, try to avoid fatty, sweet and spicy foods. This has to be reduced in their diet. These are the things which causes a lot of vomiting. Avoid fiber and avoid, of course, carbonated drinks. That is another thing. So, and if the suppose the patient itself is cooking at home and feels vomiting, we have to ask someone. So just think about pregnancy. Most of the time, ladies feel vomiting when they are cooking. So somebody has to cook for them. And if a person is having difficulty in eating, is special diabetic or heart disease, like what a cardiac disease, their requirements can be little bit relaxed. Sometimes they don't feel a particular food they cannot eat, and when we are forcing, they feel nauseated. Of course, we can take the tips from the dietitian. So we have to help the patient in which way they are helped. So communicate with the patients exactly what they really want to take, what they would like to have. And accordingly, we have to see that the patient is taking the right food. So in this, very important is explaining this to the patient and the family member, and especially the family. What causes the vomiting, nausea and vomiting, and why, and what measures can be taken to reduce it. And of course, psychosocial support, not only from the nurses, entire team, but also from the family members. And like after eating, soon after eating food, ask them not to just go and lie down. At least for some time, they have to be made to sit, at least half an hour to 1 hour. Then the patient can have a side-lying position. Then, during feeling that nauseated vomiting, what all we can do? Keep always the mouth clean. That is, oral care has to be given. Whenever the patient is vomiting, give some water to have an oral care. Let the patient, because when we start nausea and vomiting, we feel very discomfort. Even sometimes we feel difficulty in taking breath also. So loose fitting clothes are important. Fresh air. I told you that we will feel sweating, tachycardia, sometimes even we will faint. So just open and keep the windows, or just turn the fan on the patient's face. This will, fresh air will help them. Limit sounds, sights, and smell that cause nausea and vomiting. Some things, when we look on, we will feel nauseated. So that sight has to be reduced, and that smell also has to be reduced. So the cause, as I said, treating the underlying cause, correct the correctable, remove the cause. And any problem, better to call the doctor or nurse. So a review has to be done every now and then, a good follow-up. See that the patient is taking medications properly. And suppose the cause is only a wound because of the wound smell, then we have to treat the wound properly, manage the wound properly. so that the patients will feel better. I have heard patients saying not taken food for so many days. And if you ask why, they are saying my body is smelling like anything. That bad, that odor, the malodor, the foul smell. And after doing that metrogyl dressing and all, the smell reduces, foul smell reduces. And when they come back, they say, after a long time, I had my food. Family owned telling that we are not able to eat because of the malodor of the wound. Not only that, patient is not given a proper bath, catheter in situ and smelling when there is a foul smell. So these things we have to take into consideration. We have to see to that. See, a lot of chemical, non-chemical, what is it, other under gastrointestinal causes, everything we have seen. Apart from that, things are the that which we can see or which we can communicate and get from the patients. Just maybe a simple anxiety is causing nauseated. As I said, tomorrow going for a chemotherapy, patient will start feeling nauseated, thinking just about that. Fear of the injections, fear of the hospital can cause nausea and vomiting. We all must have experienced that. When we go to a new place, when the place is not familiar to us, that fear itself will cause sometimes nauseated feeling. Some food which we don't like, they are given again and again, which the food is given. As soon as we see the food, the patient starts vomiting. You can ask the palliative care nurses, they will tell you. Patients who say every day eating oats, 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 oats. And soon after, as soon as I see the oats, I still feel like vomiting. They're nauseated. These things a nurse can do. Other causes will be the which we do communicate and ask the patients about their drugs and everything. But apart from that, anytime you ask the patient what you are eating, what is your daily, 3 times oats they are having. Where we say 3 times, what we say in English, we can say like rice gruel. We say rice water they give. We say kanji in the other words. Watery type rice is given. And without anything, only just it is given. So as soon as the patient sees, the patient starts vomiting. I had experience who had the patient had come with nausea and vomiting, and you won't believe the patient had just went out. He had nice food and he came back. When it was asked, actually he had some ulcers also in his mouth, and he was feeling it very bad. It was very hot, spicy. So when I asked him, what he said was, he said, at home, all 24 hours, they are just giving me plain bland diet. That also just rice, watery rice. So he said, I was fed up. I feel nauseated because of that. So we need to find out what are the medications. And now when we come to the medication, see that medications are given before food, at least 30 to 45 minutes before food. These are the nurse's role. Taking patient comes back and says, I'm having nausea. And when they have taken the medications, after taking the food, and the patient is nauseated, then patient vomits. Because it was not explained to the patient when to take the medication. Patient is on NSAIDs. Give instruction to take the food after food only, medications after food. Otherwise, they will have gastritis. Here we play important role. And if nausea and vomiting is the cause is constipation, we have to treat for constipation. Other causes are there, which can be treated in other ways. And the patient who is in a rice tube, don't overfeed the patient. One thing. Second thing, patient is having continuous vomiting like, it's better to open the end of the rice tube cap and do a continued drainage. This we have to teach the family member. So summarizing, establish a cause. We have to find out what is the cause. reverse anything reversible, choose the appropriate drugs. That is very important. And they choose the most appropriate route of administration also. See, when we talk about, especially here, when patient who is on chemotherapy, usually they take MSIT. But the patients who are in palliative care, who are not in chemotherapy or vomiting, I think majority of the people they use is Reglan, that is called metoclopramide. Of course, opioid induced means haloperidol. Okay, and the choose of the most appropriate route of administration. A patient who is still have nausea and vomiting, if you use still oral intake, means oral route, that's not going to work out. So the change of the route is important. And of course, review regularly. At least if the patient is at home, make a phone call and find out how is the patient feeling. And this is very important in nausea and vomiting. Now we'll come to the constipation. If we talk about constipation, again in palliative care, we come across. So before going, I would like to ask, how many of you have come across constipated patients? And in what cases? I mean, what was the cause of it? Can you just put one or two in the chat box? That will be good. What were the causes of constipation? What could be the causes of constipation? Arun, can you tell me, or Shiba, whoever is there?
Opioid induced, sister.
Okay, good. After hearing about palliative care, they now know opioid induced.
Yeah.
Anything else? Only opioid?
Side effect of medicine.
Yeah, side effect. Some medications. Yeah.
Okay. No other points.
No other points. Okay. So now we will see about constipation. I think two more come.
Metabolic disturbance.
Yeah, metabolic disturbances.
Opioid diet.
Opioid diet. Okay. So what is constipation? It's a persistent, difficult, infrequent, or seemingly incomplete defecation. So it can be incomplete defecation also. So what we say is frequency, it can differ from person to person. Some people alternate days, some people daily they go, some people they go after 3 days. So whatever it is, the frequency. So it is person to person, it differs. So first we have to ask their pattern. So it called fever. It is if it is less than 3 bowel movements per week, it means the patient is somewhere constipated. And about the consistency also we have to ask whether it is lumpy, hard, loose. That we have to ask. So if it is more than 1 in 4 defecations, means in a week, it is very hard stool. It also seems like constipation. And where the patient says the patient has to strain very badly, that is also constipation. So people, it's a different. So in this case, the thing is, we have to ask the person to whom you are communicating, we have to ask a question about the defecation. So we'll come to that. And a feeling of incomplete evacuation. The patient may tell you that I feel still my bowel is not empty. It is still full. And some sense of obstruction at the anorectal. Some type of obstruction is there. It has come and it is obstructing. It is not coming out. And some people, they go and sit for a long time. And people may need sometimes manual evacuation little bit. Otherwise, they need to support their perineum so that the this one motion comes out. So it is very different. It's only when we communicate with the patient, they will tell you these things. In a simple way, if you ask a patient, so we'll come to the assessment. Now, what is the normal for the patient that I said? Ask the patient what is normal for them. Daily going. The patient may say, it is little hard, but no problem, it goes. So onset is very important. Again, when I gone back to that, the same thing, onset, constipation. Since how many days? Maybe since 2 days or 3 days. Before that, what happened? Before that, it was normal. Maybe the patient says. Ask the patient if the patient is feeling some abdominal discomfort. Like sometimes they will say nausea and vomiting. They feel nauseated. They feel bloating. Abdomen is bloated or distended. They give some patients give cramping, colicky pain, excessive gas, rectum fullness. Find out if the patient is taking laxatives regularly or on laxatives or no. About the diet, it is very important. What type of medications they are taking, not laxatives, other medications, as you said, drugs, maybe on opioids or weak opioids, whatever type of drugs, iron supplements we say. So what type of drugs they are using? What is their diet pattern? Find out what they are eating. And is the constipation very recent? It means before they never had that. And what is the, when you ask about the consistency also, there is some questions that we can ask. Ask the patient, when you go for it, when you go to the toilet, does the defecation happens easily or you need to strain? And if the patient says, yeah, I need to strain, it means, is it a hard stool? So the patient will explain to you. He may explain that, yeah, it is a hard stool, but I do not have problem. It is a hard stool and I need to strain, but still it doesn't come out. It comes out just like how the goat defecates, small pieces, just round, small things comes out. It's very small, tiny. So it means the patient is constipated. And since how long? And with this, any associated other problems, especially nausea, vomiting, that is one thing. Second thing you need to ask is whether the patient is having melena. Sometimes rectal bleeding will be there. Whether there is some patient had a history of piles or hemorrhoids, what we say, is there any history of that? So that whenever the patient goes in field, sitting, patients find it difficult. So these things will, and of course, other not things are coming, which we have to, when we ask about the assessment, when we are assessing the patient, what are the next questions we need to ask the patient? Like assess and the ability to go to the toilet. Whether the toilet is very far, patient has to reach, cannot reach, or whether they are using it as a squatting position, the patient is not able to sit for a long time in a squatting position. The timing and privacy, there is no privacy. It's in an open area. Otherwise, inside the room itself, the bedpan is given, and sometimes we don't give time. Keep on asking the patient, finish. See, whenever we give a bedpan or a urinal, we even to the children also, when we leave our children in the toilet, washroom, the mothers have a very bad habit. The mothers keep asking the child, finish? What are you doing there? Have you finished? Same thing we do with the patient also sometimes. After giving the bedpan urinal, we'll ask, finish, because we want to finish our work. Give them time, give them privacy. Sometimes in the bed, maybe if we make the patient to sit in a kneeling down position, most probably with this one, maybe the patient will be able to evacuate properly, defecate properly. and encourage, if possible, patient is taking a normal diet, encourage them to take a normal diet, and plenty of adequate fluid is very, very important. And especially when the patients are on laxatives, they need to take stimulants, they need to take a lot of water. Create a favorable environment and educate patient and family, because usually we hear from the patient, especially in palliative care nurses, if you ask, they will say, now what answers we used to get, what question they say, no, he has not eaten for a long time, not eaten enough at all, very little he is having, and how we will have his motion. And sometimes they say, no, he's not having he's having diarrhea. Now what is diarrhea, that I'll come back. Usual answer is he's eating very little, only is taking water. Now, here is where we have to explain to them about the physiology of that. I'm not going to tell you all about the physiology. At least you can say, even if he's not eating, he's only on liquid diet, motion is formed, fecal matter is forming. So that has to come out. So the causes of pharmacological, you can just go through, a lot of causes are there. These are the drugs, I said, opioids, depressants, metabolic causes, as you people have said very right. Dehydration also can cause hypercalcemia, hyperkalemia, uremia. Some neurological, like malignant spinal cord compression can cause. Structural, like pelvic tumors can cause. Any painful anorectal conditions are there, that can cause. Functions also can, irritable bowel syndrome, depression. See, again, constipation can be caused due to depression and other psychological problems. Poor diet, low fiber and low fluid intake. Hospitalization, why I put this hospitalization, that is very important. When we are in the hospital, most of the time, the people who are in the hospital who used to have a normal bowel, we won't have a bowel movement properly, because maybe the toilet is not clean, maybe the patient has to go in a squatting position, timing, because even if there will be one or two only toilets and I have to go and wait, so that also, the people who have the habit of going at the right correct time, that timing, that has missed it problems. Of course, comorbid problems like diabetic, hypothyroidism, etc. And where in some cases where the patients are sedated, they are not active on they are only bled, and of course, in advanced stages or in advanced ages. So this all can cause constipation. So examination, usually we say inspection, we have to just see whether the abdomen is distended. And remember one thing, if there is retention of urine also, patient will have constipation feeling. Motion won't come out. It is vice versa, like due to constipation, patient won't have retention of urine. Due to retention, patient won't pass motion also. So this can be. Remember about the pregnant patients, when they come on the this one bed, sometimes during this one only motion will come out and urine also will come out. So this is one. Palpation, any tenderness or mass, we have to just palpate and see. Percussion, sounds. And of course, auscultation we can do, we can hear the bowel sounds, but the bowel sounds are not, sometimes intestinal obstruction or something is there, then that is an important. So local examination you can do, local examination in the sense, you can make the patient lie down in a sideline position, just see the anal region. If there is some fissure is another thing, right? Because it's very painful. So fissure, some hemorrhoids, something is that, just have a look on the local area. And of course, we need to look at the stool examination. I remember when I talk about stool examination, I asked the patient was a case of, it was diagnosed CS stomach, advanced little bit. So we need to, because his HB was very low. So just I asked him a question. I said, what is the color of your stool? And you know what answer he gave me? He said, you're asking the color of his stool. Who is going to look at the stool? He said. And I need to tell him, you have to inspect your stool. I said, from tomorrow onwards, when you go for this one defecation, just have look at the color of the motion. because we would like to know what is the color of the motion. And he did it. The next day when the patient family came, they said the color is tarry. So it means it was melena. So that is very important. Rectal examination, as I said already, just have a rectal examination for any tenderness on palpation. And if there's sometimes they do have mass lesions also, that we have to see. Fissures, as I said. Sometimes prolapse will be there. That is called rectocilla. Especially in multigravidas, we see the patients who are very old, sometimes rectocilla what is that's a hindrance for the motion to come out. So we have to look for that also, and sometimes sensation. So this is the Bristol stool chart is there. Usually the type 1, type 2, and type 3, we say it is normal. Normal. But when type 4 and type 5, type 1, type 2, type 3, it is constipated. Because you see the first one, it is just like small lumps, like nuts it is. Sometimes it is a sausage shape, lumpy. Sometimes there will be crack, that is constipated. Normal is usual, like a smooth, it comes out well. Maybe some cuts will be there, but it's easily passed. Loose stool, they will say very watery, entirely liquid, otherwise little bit is a loose stool. The amount is but less. So goals for managing constipation is relieve the pain and discomfort of the constipation so that patient's quality life becomes improved. And re-establish a bowel habit to the patient's comfort and satisfaction. Restore optimal level of independence. Consider individual patient's preference and prevent or treat related gastrointestinal symptoms. We are coming to that. It's a non-pharmacological and pharmacological. So many electro products are there. I'm not going to talk. In palliative care, we use more of stimulants and of course softeners, what we say. One is bisacodyl, what we use. Other bisacodyl we use a lot. And other things are something like stool softeners we use. Cremaphene, liquid paraffin, this type. Okay. And the third, when we talk is about the suppositories, what we use. Suppositories are and enemas. So in constipation, prophylactic we can give, as we talk about opioid induced constipation, we can use a stimulant or a softener, otherwise both. So we have to see that whenever doctor prescribes, whether the doctor has prescribed a laxative or not. If not, just go to the doctor and say, this patient may need a laxative. But once you have established that it is constipated, so better thing is to empty the rectum or the soft stools and then add some oral medications. And if the patient is on impacted rectum, better to go for suppositories, enema, and manual evacuation. I will talk about that, impacted rectum. And before that, suppose when the patient has come to you and patient says, my stool is hard, but still I am able to pass. And the patient is only in a stimulant, better to add a softener. And usually palliative doctors, they do add softeners. If not, at least as a nurse, we can just go and tell the doctor, this patient is saying the patient is finding difficult while passing motion because it's very hard stool, so that they can write down a softener for the patient. And if the refractory, nothing works out, everything is a block, then we go for a higher enema. Now I'll talk about that. So in opioid induced constipation, already we were prescribed a stimulant laxative, titrate the dose accordingly. And if the bowel is not open for more than 3 days, give suppositories. We can keep bisacodyl. So I would like to ask this question before you all can answer. How to insert a suppository? Because if you are inserting, otherwise you are going to explain it to the family member. When you get a suppository, how you insert, how you will explain to the family member how to keep the suppository. Okay, so when we have an open discussion, I'll be asking this question. So please, you all be prepared. Okay. And if this is ineffective, administer a phosphate enema. So now, when a patient is having the maximum dose of stimulant laxity is ineffective, then we can add two things, a softener and half dose of the stimulant. In some persons, that is again, when you assess the patient, ask the patients after taking a bisocordyl, that is any stimulant, if they find some intestinal colicky. Like me, I cannot take a intestinal laxative, stimulant laxative, because I will have a very bad cramps, even I will faint, because I had it 2 or thrice time. I had experienced this. I used to have severe abdominal cramps, and I used to sweat, and then I will faint also. So we need to find out about that, because sometimes because of that, the patient will stop taking the medications, but we won't know. So we need to ask about that. Then is the PRE examination, manual evacuation, and enema. That I'll come back. This is about the constipation in paraplegia and quadriplegia. I'm not going to much detail, where they say if it is about in T12 and between L11, usually responds to a digital stimulation of the rectum. And if it is below T12, here also generally requires digital evacuation of the rectum, where there is a flaccid GI tract. Lesions at the level of the cornus medullaris may manifest a mixture of clinical features. So usually whenever a patient is a paraplegia and quadriplegia, sometimes digital evacuation usually helps the motion to come out, so that we can help with the patient or teach the family member. So the patients who are having fissures, anal fissures, please see that just to put little bit of, see, I'm talking about this on a practical experience. I'm telling the patient is having fissures, otherwise patient is finding difficult while passing. Just a little bit of silocaine jelly you can ask them to take, and just to apply it on the anal region, and then they go up, wait for some time, they can go for a defecation. At least the pain, local pain will be reduced. So that we can, what to say, we can explain to the family members. Oral measures is the best. What we do usually, oral measures, increase the fluid intake, adding of stimulant laxative. So in impacted with feces, empty the rectum digitally. If there is spastic GI, developing the daily routine. After waking up in the morning, 1 to 2 bisacondyl suppository may help in these cases. Then encourage to have a hot to stimulator. Some people need to have some hot things to drink to stimulate it, so they can pass. And some feces will be explained if there is a strong sacral reflex, some feces will be expelled as a result of the above two measures. So in any of these measures, after taking up in the, that is as soon as we get up in the morning, to take 1 to 2 bisacondyl suppositories, or take something, encourage them to drink something hot. And if it is, there is a strong reflex is there, this will be expelled. Digitally stimulate the rectum. Sometimes they need to digitally stimulate the rectum so that the motion will come out. Insert a gloved and lubricated finger, either soap or gel. People do try these things also. And of course, in palliative care, we don't try all these things. But I know a little bit of soap, if you apply, sometimes it helps. Okay. Then rotating the fingers 3 to 4 times. And withdraw and wait for 5 minutes. Maybe the patient will be able to pass. So prevention is better than waiting until the intervention, and the aim is to achieve a comfortable defecation. So before going into that, when a patient is constipated for more than 3 to 4 days, already on laxatives, stimulants, and plus softeners. Now the patient has come to you already. You have taken the history of the history from the patient, and you found out the patient is constipated. Hard stool cannot come out. Now here is the thing, what we do is, first and foremost is explain the procedure. As you all know, we are nurses. We do always tell, explain the procedure, be at the patient side. Okay. Now next is rectal examination. When you are with your gloved hand, please see that you put enough of silocaine jelly. Slowly, gently do it because it's very painful. Just put the finger and examine. If the stool is hard, you feel, then you have to start removing the hard stool first. Without removing the hard stool, if you give enema, it is not going to work out. So try to remove the hard stool, whichever is there in the front, remove the hard stool. After removing the hard stool, then give enema. So here in palliative care, again, when we see there is an impacted rectum, we usually give a high enema. High enema in the sense what we do is, the phosphate enema. That phosphate enema, the tubing is hardly 3 to 4 centimeters. So what we do is, we attach a suction catheter into that. Otherwise, if you have a enema catheter, well and good, you can just attach to that. And that is first introduced inside the rectum. So it will go a little high up. Then you squeeze the enema. Hold it for some time. Then let the patient go to the toilet. Without removing hard stool, if you give enema, what happens is only whatever is there, because this tubing will go inside in between the motion, fecal matter. So only that much will come out. So the patient won't have a satisfactory defecation. See that it goes until up. I'll give you a very, this one incident, what has happened with us was, a patient had come and she has two things happened. One, patient's son said, since past 3 months, we are not able to introduce a catheter. Means catheter is not. She was in a urinary catheter, Foley's catheter, indwelling catheter. Second thing, since past 15 days, she has not passed motion. This was what the son has given. Okay, now son went, the daughter-in-law was sitting there. So I just went to communicate her. I just asked, which was your last bowel movement? And suddenly this daughter-in-law, she said, just 3 days back only she had passed. So I just turned to her and I told her, I need to talk to you also, but let me ask first the patient. I need to know from her. So, and this patient was looking at the daughter-in-law. Then I said, see, you can talk to me. You just tell me what happened. Then she told, since past 15 days, I have not passed. And to my surprise, she was not given any laxative also, because daily she was passing and this daughter-in-law had problems. So that was not given. So then we had to take, and why? Catheter also is not introduced, and she had incontinence, frequent, little bit, it was coming out. Bladder was full. Okay, so we had taken, and you won't believe, when rectal examination was done, the staff who had done, she came out and she called me and she said, my finger is not going inside, it has bent like this. It was just like something like a cement it was inside. So hard it was. We had to give a glycerin suppository for the patient. First day we gave, second day also, 2 we have to put. We had to wait for that. And by the third day only, actually, it became little bit soft. And then we could remove the hard stool which was there in the front. We removed that stool. Then we had put the this one, enema. Then we gave the enema. So 2 days we had to give. We had to continue it with that. And after that, we were able to put the indwelling catheter also, because the catheter was not going because of this constipation. This is only one incident I am saying. Several incidents. Patient came rolling and crying. Husband has taken her in the arm. And he was telling, since last night she is howling. When asked, taken history, it was just constipation. We had to just give her some medication also to relieve her pain. Then same thing, per rectal exam, hard stool was removed. We gave enema. The patient who went inside on her husband's arm came by walking out. And she said, no need of staying here, no need of admission, we will go home. And just because of that constipation, the patient was not eating also due to nausea. She was complaining of vomiting, nausea and vomiting. So taking history is very important with the nurses because that is our duty, and informing the higher authorities. So diet, as I said, diet, increase fluid intake, privacy had to be given, commode rather than a bedpan, mobilize if possible, and stop or reduce constipating drugs if possible, wherever it is possible. And prescribe daily stimulant and a softener, especially if the patient is on opioid. Escalate doses until the bowels are open. If maximum dose ineffective, reduce by half and add another one. And the bowels are not open for more than 3 days, please go for any rectal measures and ask the family member to continue with the oral laxative. This we have to sit and talk with the family members, communicate with the family members the importance of giving oral laxatives. And if not given, what are the consequences going to happen? So constipation should be considered in all palliative care patients. Prophylactics can be given. Consider PR examination and remember the non-drug measures also, and titrate oral laxatives. And thank you. And before stopping, even in diarrhea, there is a problem in palliative care. I'm not going to talk about diarrhea. Diarrhea means we tell as it is spurious diarrhea. I showed you one slide that overflow diarrhea we say. The family member will say patient is passing little bit of stools, but it is loose stools. Amount is very less, but little bit is coming, it is loose stools. So go for the history. When it started and what before the onset, what it was. So they will give a clear picture. They will say, yeah, since past 2 days he is having a loose stool, but before that it was constipation. So here also go for a PRE examination. If hard stool or loose stool is remove it and then give a enema. So spurious diarrhea is very important again in palliative care. In palliative care, they will give you the history, but only see that the proper history is taken.
Thank you, Sister Stella.
Yeah, my question, I hope someone can answer. We will ask about that, Shiba. Is
Yes,
there time?
Yes, you can.
So I asked a question, how to keep a suppository, how to insert a suppository, how you will explain. If anyone can just unmute yourself and explain it. Anyone from the group. Because that is very, very important. Shiba?
Yeah, Sister.
I think nobody's answering.
Hello.
Yeah.
Yeah.
Regina.
Regina.
Yes,
Okay.
please. So I just want to try. I think first of all, you have to explain to the patient what you are going to do. So now that we know that the patient has constipation and then we want to insert suppositories to help to soften the stools and bring them out, you tell him that this is the reason why you are going to do that. And then you want to help so that you'll be able to expel the stool.
Right.
And then when you are done, then you ask the patient to lie down on a bed and on his side, like laterally, so that you have a bigger view, if I should put it that way. The buttocks and the anus is a bit exposed in that position. And then you, the health worker, you are in gloves. So if the patient is, the heavier type or a big adult, you can ask for assistance from your colleagues or from the caregiver if the patient will feel comfortable that way. And then they will assist you. So you pat the buttocks and then with your other hand, with the suppository in your hand. Most of the time, our suppositories have two ends. So one end is pointed, the other end is blunt. So you insert the pointed end, you use the pointed end, and then when you part the buttocks, you gently insert it and then try to go a bit deeper so that it gets into the rectum. And then before then you remove your hand. So after that, ask patient to lie down in that position. Tell him not to try to push or expel anything out. And then lie down quietly in that position for at least some 2 to 5 minutes before he gets up, so that the medication will not come out. Yes, so that is what.
Yes, Sister Regina, almost you are correct. But one thing you have to tell them, especially the family member, if you are communicating with, if you are explaining to them, as you said, yeah, the pointed end has to go. First one thing is, if she finds hard stool, that hard stool has to be removed. That is one thing.
Okay.
Okay, because if there is a hard stool, what happens? Just I will show. See, suppose this is a hard stool is there inside. Okay. Now, when
Okay.
you insert, what happens? It goes in the center of the hard stool,
Okay.
and it's not going to work out. Okay. What we have
All
to do,
right.
when you insert it, see that it is touching the mucosa of the rectum.
The rectum. Okay.
Yeah, because see, even in delivery cases, when we are giving a patient to induce labor, when we are introducing medication, we always try to keep it on the vagina, right? Because when we touch it
Yeah.
only, it will start working out, right, Regina? So same thing,
Yes,
what happens,
please.
the rectal mucosa is there, the suppository has to touch the rectal mucosa, otherwise it is not going to work. What happens if the patient little bit strains, the suppository will come out with the motion, with the stool. Okay, so everything is good,
Okay.
what you said, explanations are like that. But only one thing is, this thing we have to say. And second thing, whenever it is taken out of the fridge, I mean refrigerator, you know, immediately we have to do is, some people what they do, they will take it from the refrigerator, they'll keep some time for outside. By the time what happens, it starts melting.
Melting.
Yeah, so it is very difficult to insert, and tell them to remove the cover also, the covering of the suppository,
Yeah.
because we have come across the people who had put with the covering, they were not knowing, because it was not explained. We cannot what to say, blame them for that. So explain to them, we have to remove the cover, the pointed end has to go inside. And when it goes inside, if hard stool is there, first we have to see, remove the hard stool. And if they feel they cannot remove the hard stool, just see that it goes inside and keep it on the mucosa of the rectum. It
Mucosa.
touch there and keep for some time your finger, and then slowly remove your finger. Okay.
Okay.
Thank you so
All
much for
right.
your answer. Okay. Thank
Thank
you.
you.
So, okay, Shiba.
Can we move on to the case presentation?
Yeah, sure.
Mrs. Jenny will be presenting the patient story today. Sister Jenny, over to you.
Hi, good afternoon, everybody. Hello.
Yeah, we can hear you.
Yeah, we can hear you.
So can you move this? I am Jenny from Kerala. Today we are discussing about one patient, 35 years old female patient, diagnosed metastatic melanoma stage 4. Presenting complaints: nausea, vomiting, depression, fatigue, thinning or loss of hair. History of illness: she had a history of skin allergy with the symptoms of erythema, itching, skin rashes 6 months ago. She was diagnosed with metastatic melanoma 2 months ago. Underwent 2 cycles of chemotherapy. Admitted and got discharged after chemotherapy section. She developed chemotherapy can cause side effects such as nausea, vomiting, depression, tiredness, and thinning or loss of hair. Examination: patients conscious and oriented and vital senses are checked, and they're treated for the tiredness, nausea, vomiting, abdominal pain, weakness, and loss of hair. Treatment and significant investigation. Routine investigation done. Treatment includes nausea, vomiting, abdomen pain, like this, whatever the patient condition, like this, we are doing the treatment. Providing comfort and adequate rest, giving small and frequent oral food to prevent the dehydration. Nutrition, protein-rich bland diet that is easily digestible. Planning things at the time of the day when she feels less tired. Spending the time outside in the fresh air each day, doing mixed exercise and facing herself. Psychological aspect. 35 years old married woman living with husband and two kids in own house. The only earning members in her husband. She is having more faith of God and regularly following all customs. She is interested in reading spiritual books. Medication. Usually, she is taking only IV androsterone and 4 milligram and tau pantoprazole 40 milligram. If they if they want to do any medications or she has any pain or infected, they will do the investigation after they will start the antibiotic and antibiotic. If they have too much pain, they will give the Tramadol also. Sometimes she have the any itching or they will corticosteroid ointment also they will apply it. Main concern, fatigue and weakness, prevention of injury, pain management, prevention of dehydration. Summary, 35 years old female married woman with stage 4 metastatic melanoma had a 2 cycle of chemotherapy cycle and chemotherapy side effects. Discussion point. Prevention of injury related to weakness, prevention of dehydration related to vomiting, and need of spiritual support. Thank you.
Thank you, Sister Jenny. Anybody would like to need any more clarification regarding his patient story? So otherwise, we can move on to the discussion points. So I would like to know what do you mean by prevention of injury related to weakness?
Yeah. That also. What is prevention of injury related to weakness? Yes, Sister Jenny.
After vomiting, she had the weakness also. Sometimes she is walking. They will they feel for the fall.
Fall, you mean? Prevention of injury. You mean prevention of injury related, this one, related to weakness. Yeah.
Okay, thank you.
And prevention of, this is almost the same, like prevention of injury related to weakness and prevention of dehydration related to vomiting. So whenever the patient is having vomiting, automatically the patient will become weak only. So there is a this one question of falling or finding injury. Okay. So here the patient, as you said, Jenny, chemotherapy related things may be there, right?
Yeah.
Because the patient was on chemotherapy and that is why the patient is vomiting. And we can say as a psychosocial, psychological other problems also, because 35 years old, metastatic melanoma, very young, metastatic melanoma.
Yeah.
I don't know what must have been told to the patient and the family about her condition. We don't know about that. Okay.
Yeah.
So at least we need to sit and talk why she's not having her food. That is very important. About her medication. So first and foremost thing is about her medication, whether she's taking the medication regularly or not. That is one thing. Okay. Even after taking the medication, if she's vomiting, maybe they need to change the medication.
Okay.
That is another thing.
Yeah.
Next is, because if she's taking properly the medication, then about the food, about her diet, we can think about.
Yeah.
So then we have to talk about the diet. What food she can have. What type of diet she would like, especially after chemotherapy. Usually we say to have a light diet in the sense bland diet, because eating more of spicy food and all, what happens, usually they sit and vomit. They have that nauseated feeling, they will have gastritis. As such, chemo will cause all these things. And to top of that, when we are eating all this spicy and that type of food, we will have. So they should eat more of light food, more of soft diet, soft food in the sense boiled food. See, with the cancer patient, there is a thing. Soon after chemotherapy, they should have a easy food, means a digestible food, easy to digest, small frequency, small amount and frequency. Also, they can cut off like every 3 hours or 4 hours. They can take little bit. Okay, more of boiled food, fried items, and these things they have to reduce. More of boiled food they can take out. And to prevent constipation, so they had to add little bit. So to prevent constipation, they need to take more of fluids and fiber diet. That we have to see. So if we improve her nutrition only, she will be better. So we can prevent that weakness. Weakness is due to reduce in nutrition. Her nutrition is not proper. So to improve her nutrition, we have to communicate with her what type of. So maybe you need to, if you have a dietitian, you can call in a dietitian and talk. Otherwise, you yourself can go through and see what all food we can give her and what all food she is taking. I need a question from Sister Jenny. This patient is from Kerala.
Yes, ma'am.
Yeah. So the next question is, you said the prevention of diarrhea related to vomiting. So vomiting food, some of things which we eat in Kerala. One is puttu. Puttu is very bad. It causes gastritis, and especially puttu and having that chenna and curry and all now. Kadala curry, what
All
we
the
say.
spicy foods are there eating, they are coming the vomiting.
So now, first and foremost, so now what I said before is very clear. Please explain to the family member and to the patient, these type of foods will cause vomiting. So to reduce that food, to avoid that food soon after chemotherapy, and to go for normal boiled food. No fried items, no spicy foods. They can just go to have all these things. That is very, very important. Improve, they can have even fruits, but fruits also again like grapes and all, they should not have. Grapes is not good because on the grapes they use lot of chemicals on the grapes, so not grapes. Other easily digestible, this one, and remove the skin, and if there are little bit inside, what to say, that nuts types are there, the peels and all that they have to remove. Okay, and remove peel off the skin also, like apple. Don't give apple with the skin, to remove the skin. Okay, so this type of food you have. Now when you talk about fluids, water is good, but boiled water you have to give after boiling, cooling only, because we are preventing patient in chemotherapy, we have to prevent infection for them. So that is also important. Okay, so boiled water, fruit juices, fresh fruit juice, what I mean. Okay, fresh fruit juices can be given to the patient. Okay, even at home itself, they can make this dal and all. When they make that itself, they can give little bit, they can remove and give to the patient. Okay. Now, when we talk about and prevention of injury, that is another thing. When a patient after chemotherapy, patient is feeling weak and all, somebody has to accompany the patient to the washroom and these things. That also you have to explain. Now you're talking about a need of spiritual support. Okay. So you said she likes to pray. What is it? She likes to prayer and all.
Yeah, she need the spiritual books they want read always.
And what more spiritual support she needs then? I didn't follow.
Some days they are thinking why they are coming like this. This is not my fault.
Why this happen? Yeah, why this happened? See, we say spiritual is why me? Why this happened to me? Right?
Yeah.
And we have to ask a question. We can ask her why she's thinking like that. Why that thought has come for her that.
Yeah, she's a very young
Yeah,
she's very young lady, but she's thinking I am always praying and then reading all the spiritual. She's not doing nothing for others. By they are coming for me.
And
like
Sister
this.
Jenny, there is no answer for that also.
Yeah, no, she is thinking like this.
Yeah. See, we say in palliative care, for some questions there is no answer. We have to just sit and listen to the patient, because there will be a lot. First of all, first and foremost thing, Shiva will agree with me. You should know what is spirituality. You need to know what is spirituality. Is not always religious. There are a lot of other things in spirituality. Spirituality is something about the meaning of the life. Some connectedness, lot of things are there. It's a lot of events are there in spirituality. So we need to know about spirituality first. You should, I think we will have a class, I think. Shiva, they will have a class on spirituality, right?
No, no, no.
No, oh yeah, sorry. Okay, see, spirituality is something. When we talk about spirituality is what it means, the meaning of our life. So we need to see. So for example, I will say, when I look at a flower, I feel happy. That is spirituality. Even praying is also spirituality with the gods. This one, that is also spirituality. I don't think that is not spiritual. Some people connect it with religious things. Like I do evening rituals. When I pray, I feel better. That is also spirituality. But inside the spirituality also, a lot of other things are spiritual distress and spiritual pain is there, where I am not able to forgive others for what I have done. I am not connected with many people. Maybe I am not talking with my sister, I'm not talking with my brother, there was some problem. This all comes in the spirituality. So spirituality is a vast subject. You have to sit and talk to her patient. Sometimes you have to go back to the history about what is her connections with her family members and others. If something has hurted long back, something is there in her mind which she wants to talk to you. As you said, she said, I'm always praying and still it has come to me. So you have to sit and talk to her. Maybe there is some event, something is there that is pricking her, that is giving her pain, spiritual pain. So maybe after talking to her, she may come out with that, so that you can connect with that. For an example, I will tell, suppose I am angry with Sheba. I am not talking to Sheba. But before dying, that hurts me very badly. It keeps on coming to me, just like vomiting. It keeps coming, nauseated. Okay, say she did not do, but why I hated her, why I spoke to her very badly. I need to reconcile. I want to talk to her. Okay, so it keeps on hurting me very badly. Okay, so maybe if someone comes and talk to me for some time, and suddenly I ventilate it. It is some emotional also. I ventilate it. I say, see, long back I had a fight with her, and I would like to talk to her. Uh, so suppose Shiva comes to me and I talk to Shiva and I feel better, and that is where that emotional thing, no, what to say, that anger or that um, whatever that feeling, na, that sorrow, everything goes off. I will feel better. Okay. So maybe this lady is connecting something to religious also, like what we say, if we Christians, we say we should not do bad to others, and these things, a lot of things are there. I'm not going detail into that. Okay. So we need to sit and talk to this patient. What is her spirituality? So usually we say you should know what is your spirituality, then only you will come to know what is the spirituality of the patient. That is a vast subject. If I start talking today, there is no enough time for that. Okay, so you should know about spirituality so that you can sit and communicate with the patient and come out what is her problems. It's together. There will be some things that she want to tell you, and then on that we can then talk to her.
Okay.
Okay, so
Okay.
why me? If she asks, you cannot say to her, I don't know why. Because there is no actual answer for why she got it. I also don't know why she got it. Only thing is we have to sit and talk about that. Sister Shirley has written, we are daily working many patients with vomiting. Stella, madam, your explanation. Oh, what you got? Okay. So these are the some things. Shiva, you want to add something? You can add.
Sure.
Yeah, this was Regina has clearly said, with spiritual aspect, we should assess her spiritual needs, ask questions and help her where necessary. And if she could need a religious person in his management, then we can arrange for them. That is very right. Thank you, Sister Regina. Sister Jenny?
Okay, ma'am.
Any more questions?
No. No, ma'am.
Others?
Others, any questions? Anyone?
So no more questions,
Shima?
sister. We can wind up here.
Yeah, yeah.
So,
Thank you so much, Shiba. And thank you all the participants.
thank
Thank
you,
you,
Sister
sister.
Stella, for the excellent presentation, and thank you, Sister Jenny, for the patient story. Thank you once again, all of you.